disease, primary osteoarthritis, intrinsic defects in the articular cartilage. So we get degradation of the articular cartilage, joint narrowing, so that space gets very narrow between the bones, joint space narrowing. Bones are getting close to touching. Eventually, joint becomes non-functioning and very painful. Synovium may become mildly inflamed, but remember that DJD, osteoarthritis, is mainly a disorder of the bone and the cartilage, not the synovium. Rheumatoid arthritis, which we'll learn about next, is a disorder of the synovial membrane. Obviously, increase with age, and hereditary. There is some hereditary issues with osteoporosis, so always osteoarthritis. So ask about family history in your family of anyone with osteoarthritis. Secondary causes has a source. Congenital things, trauma, crystal deposits. So like gout is a secondary cause of osteoarthritis because it's an inflammatory process. Once that goes away, that should usually go away as well. Infection, metabolic disease, endocrinopathies, your PTH, osteonecrosis, and a hemarthrosis. Okay, different types. Chondromalacia, patellar surface of the femoral condyle in young people. Pain and stiffness of the knee. So that's one type of osteoarthritis. Etiology, increased unit load. What does that mean? When we lose articular cartilage, that means the surrounding cartilage have to pick up the slack. And what happens is, let's say that is now what is left of our bone and our cartilage. And this is the next one, the one on top. Because we lost all that bone and cartilage there, that point and that point are now under increased stress from that joint above it. Let me put it a little higher. So there and there are increased stress on those points now because they're the ones that are sticking up. Eventually, over time, those will get worn down, and whatever the next highest peak, that's the next point that's going to be loaded upon. So that's what this single point is talking about. Increased load on less surface area. Once the unit load is exceeded, it can't support the weight that you put on it, chondrocytes die off, and we get degradation of that articular cartilage. It starts to wear away. We get decreased resilience of that cartilage, increased stiffness of subchondral coarse cancellous bone, so all that deep stuff. When you damage the coarse cancellous bone, which is inside of the bone, this part, increased unit load on cartilage from unit stiffness. And mechanical forces are not transferred by normal stress, but they're dissipated by micro fractures. So they start breaking the bone. Stress fractures, especially what this is. Stress fractures. Mainly is going to involve our proteoglycans because proteoglycans allow the connective tissue to withstand compression. And that's why proteoglycans are important, but they start to decrease with osteoarthritis. Chain length is reduced, protein synthesis declines, and fails to respond to reparative stimuli. So our normal repairing process is now diminished. Chondrocyte cell replication diminishes, so we're not going to make new cartilage. That chondrocytes go away. Chondrocyte apoptosis, so it destroys them. And we get decreased synthesis of type 2 collagen. So if we decrease the collagen, the strength of that joint goes away now. So that's why collagen is so important. Anyone here make soup at home? Like a stock? So the way you know that you did a really good job is with the bones, that the bones have the collagen in there. So if you let it, heat and simmer for hours, all that collagen comes out so that when you put that soup or the broth in the fridge, when it turns to like Jell-O, that means you got all the collagen out of the bone. It's going to be a very, very flavorful soup. So that collagen is what does it. Gelatin, Jell-O, is collagen. Gelatin, that's why they call it. Anyway, you get also product of inflammation, your nitric oxide comes out, and they trigger further breakdown of the cartilage. So let's look at the actual cells now, what's happening. First thing that happens, we get cracks in that hyaline cartilage. And when you get cracks in that hyaline cartilage, remember all the hyaline, or not the hyaline, all that synovial fluid starts to invade those little cracks that are made in that articular cartilage. So now we got fluid invading those cracks. Okay, and there we go. So cracks in the cartilage allow synovial fluid to start to invade that space. The synovial fluid should not be there. Okay, then that crack gets bigger. Now we start getting into where the bone is, and that's where the vessels are. So that's where you get some bleeding going on there. You get cloning of chondrocytes. The synovial fluid is still invading this area. Then we get a fibrocartilage plug. We have to repair that tissue. We can't leave that area there by itself. Okay, so new vessels grow into that area to repair that damage, but it doesn't repair it in the right way. So we have this now, this cyst that forms, the subchondral bone cyst, subchondral below the bone. And that's where the synovial fluid starts to plug in and get invade that space. So fibrocartilage plug is not sufficient and may get worn away. So that plug that we made right here is not very stable, and it can get worn away with repeated use. And then therefore, that fibrocartilage plug becomes thickened and eburnated or degenerative of bone. Bone is worn away. If there's a crack again, synovial fluid keeps leaking in, and it causes that bone cyst to occur. And focal regrowth of the articular surface causes osteophytes to form. So what happens is the bone is replaced by that. So you'll see osteophytes on the x-ray. We'll show you that in a second. So here's another way of looking at it. Here's your normal joint. This is with osteoarthritis. Again, we have cracks in the cartilage. We have hyaline, or the synovial fluid, leaking into those cracks, causing those subchondral cysts to form down here and up there. Now, let's go to the more advanced form of osteoarthritis. We get osteophytes. So whenever you see osteophytes, think of osteoarthritis. They usually go together. So it's replacing that tissue with these osteophytes, which don't have the same properties as normal cartilage does, and it causes more pain. So clinical manifestations, obviously joint pain with movement or weight bearing, improves with rest. So if they're not using that joint, the pain goes away. Pain signifies joint destruction. So as we're having pain, that joints are being destroyed. Joints may become enlarged, boggy, or tender. You get crepitus, stiffness, restricted joint movement. What normally happens also with these patients, if they have arthritis in the knee, when they walk, it hurts their knee. So what do you think people do when their knee hurts? They change the way they walk so it doesn't hurt their knee so much. But the problem when you do that is the joints above and below aren't used to walking in that way. So you start getting hip pain or ankle pain because of your knee, and you're walking in a way to not hurt your knee, and it results in you hurting your hip, little soreness in it. It's not going to cause osteoarthritis, but you'll get some joint pain from being used in a different way that you're not used to walking. So imaging. Okay, these are the osteophytes I was talking about. Okay, increased density of subchondral bone Again, whenever we repair bone, it gets brighter white because more calcium is going on to that, so it goes white. So those are the osteophytes that you'll see. Also, if you look on those joints, you see pretty good joint space in those joints. Ever see the joint space? Now look at this one. Very, very, very thin joint space because of the osteoarthritis. Okay. Everyone good? And again, there's no joint space there. That's bone on bone. Very, very, very painful. That is like a last sliver of whatever joint space is left. But the rest of it is just bone on bone. Okay, the next one we'll talk about is rheumatoid arthritis. Rheumatoid arthritis is an autoimmune disease, and it presents with polyarthritis. So they have arthritis in different parts of the body. It usually is going to be symmetrical bilateral joints, both hands, both feet, not just one or the other. Usually both hands, both feet. MTP joints, elbows, knees, ankle, spine. Usually begins 5th or 6th decade. Any age, more women than men have rheumatoid arthritis. Wide range of clinical presentation for this. Waxes and wanes, so they have these remission and the exacerbation episodes for that. Some patients will never recover, and some develop serious progressive diseases from this rheumatoid arthritis. Etiology, unknown, but there are obviously some genetic or environmental factors. Genetic factors, your HLA or MHC is the most significant with regards to rheumatoid arthritis. Other genes like these cytokine promoters may also propagate inflammatory responses. This is an inflammatory disease. Rheumatoid arthritis is inflammatory. Non-genetic factors, smoking, obviously they're going to have this autoimmunity. So autoantibodies like rheumatoid factor is an autoantibody, and this ACPA. Now, this is considered seropositive rheumatoid arthritis because we see rheumatoid factor or ACPA, those are the seropositive antibodies that are leading towards rheumatoid arthritis. What arthritis do we learn about, which is seronegative? Psoriatic arthritis. It does not have any inflammatory properties, it's just from the psoriasis. So psoriatic arthritis is a seronegative. You're not going to see rheumatoid factor or ACPA in a patient with that type of arthritis. And again, all contributes to inflammation that occurs in the joint synovium. This is not a degradation of the cartilage. This is an inflammation of the joint space. So the joint synovium is markedly abnormal. Activated cells, inflammatory cells, B cells, T cells are all there. The synovium lining becomes very, very thick, 8 to 10 cells thick. Normally it's only 1 to 3 cells thick, that synovial membrane. Not very inflamed, but here it gets start getting very thick, and you get some vascular changes as well. This is very important for rheumatoid arthritis, is this pannus. It's the abnormal layer of rheumatoid arthritis synovial tissue. Okay, so that inflammation that's going on starts to invade the joint space is called a pannus. It invades and destroys adjacent cartilage and bone. That's what a pannus is, and it's from the rheumatoid arthritis. So you can see here, here's your normal synovial membrane. Look at it on that side in red. You see how thick that is. That synovial membrane, very, very, very thick. Then we get pannus, which is the destruction of the adjacent cartilage and bone, right? So all these different cells are in the area, and our synovial fluid has a lot of neutrophils in there as well. So that's pannus. So you can see how the synovium is starting to invade and leak into that cartilage. Nothing to do with cracks in the joint. These are all autoimmune. The body's attacking itself. So here's a narrow way of looking at it. So this is looking at something called ankylosing spondylitis. So ankylosis is spontaneous bone fusion. So here is your normal rheumatoid arthritis. We have our pannus formation, inflamed synovium, erosion of the cartilage due to this inflammatory process of the pannus. Ankylosis is when the bones fuse and that joint will not move again. Usually this happens for ankylosing spondylitis in the back lumbar spine. Again, this is dating me, but you guys know the band Motley Crue? The guitarist for Motley Crue has ankylosing spondylitis. So he doesn't move very much on the stage, but he's there. Physical exam for rheumatoid arthritis, joint inflammation, pain, swelling, warmth. All these are hallmarks. Morning stiffness, wake up in the morning, they're stiffer. In osteoarthritis, when they wake up in the morning, they might be a little bit stiff, but once they start moving, it's going to go away. It's just from being in bed all night. Multiple small and large synovial joints are affected symmetrically. Small joints of the hands, wrists, and feet, or the bigger ones, your hips, knees, shoulders. The synovial joints become demineralized. Okay, joint cartilage and that bone are eroded by that synovial inflammation. Again, pannus. If it's in the cervical spine, they may have cervical instability. They can't hold their head up anymore because of the rheumatoid arthritis. They can get subluxation of the joints or joint fusion, the ankylosing. But again, bony erosions and joint space narrowing is the hallmark on X-ray for rheumatoid arthritis. Now, these are some of the severe symptoms or signs later on, and these all have different names we'll talk about in a second, but you can see how these joints are deformed in the hands and in the toes. So late stage, symmetrical polyarthritis, so both hands, just like you saw, both hands, both feet. Whereas osteoarthritis can just be, my right hip hurts or whatever. Rheumatoid arthritis is bilateral and symmetrical. So boutonniere deformity of the thumb, ulnar deviation of the metacarpals, swan neck deformity of the fingers. These are three different things, techniques, or descriptions of the finger changes seen with rheumatoid arthritis. Extra articular manifestations. So rheumatoid arthritis is not just going to cause a problem with the joints, it can also cause problems elsewhere in the body. Cardiac, pericarditis, pericardial effusions, rheumatoid nodules in great vessels, because they can make nodules. Great vessels, myocardial wall, cause issues with the lungs, pulmonary nodules and effusions, ophthalmic manifestations. So rheumatoid arthritis can also cause issues with your eyes, neural symptoms, and here's your systemic vasculitis again. What do they get with vasculitis, with derm, or what could they get? Palpable purpura. So these are some rheumatoid nodules that they will get with rheumatoid arthritis. And here's again, signs and symptoms of rheumatoid arthritis: systemic polyarthritis, bilateral, rheumatoid nodules, ulnar deviation, swan neck deformities, boutonniere deformity of the thumb, all different things. Serology is going to have a rheumatoid factor. So again, oh man, we're almost done anyway. So they're going to have that seropositive. 55, okay. 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 So this is a great summary slide if you want to start it for normal joint osteoarthritis and your rheumatoid arthritis. Let's look. Bone ends rub together. Degradation of the cartilage. Is there any inflammation going on really with the osteoarthritis? Not much inflammation. Now look at the rheumatoid arthritis. Okay, bony erosions. swollen, inflamed synovial membranes, inflamed synovial fluid. You know, the fluid inside has all the properties inside, all the things that cause all the issues. Oops. Okay. So that's a good summary slide. Okay. Last little bit is on neuropathic joint disease, mainly called Charcot joint. This is another one. Go to Disney. You'll see this all the time. Okay. Secondary non-inflammatory arthritis, most common with peripheral neuropathy. What is Charcot joint? Peripheral neuropathy. These patients cannot feel what they're walking on. So if they walk on a Lego, they're not going to feel it. But what's the problem with not being able to feel what's under your feet? You'll step on things and damage your feet because you don't feel the pain, so you keep going. That's why when you go to the dentist and they give you the shot, the Novocaine, they're like, don't do anything for a little bit because you can't feel the pain. You can bite your tongue really hard and cause damage because you don't feel the pain. Neuropathic joint disease, they don't feel the pain, so they have repeated injury to the bones. Progressive joint destruction due to a primary neurological disorder, peripheral neuropathy. Syphilis can also cause these as well. Loss of sensation to the lower extremity can lead to that Charcot joint. Diabetes is the most common cause because they get peripheral neuropathies. Other causes of a Charcot joint: chronic alcoholism, leprosy, hereditary insensitivity to pain. Okay, there's a couple people that they don't feel pain. It's very, very rare, but it happens, and multiple sclerosis as well. So, secondary key component. First one, you have to have a peripheral neuropathy. You have to have a way to not feel a pain. The second thing is preceding injury or trauma to the joint. Obviously goes unnoticed because lack of normal sensation. They don't know that they're feeling these issues. So lack of poor sensation, injury may not be perceived to be serious, and they continue to do what they do all the time, and they cause repeated damage to that joint. So the joint essentially fragments, marked destruction of articular cartilage, cyst formation, subchondral sclerosis, products of bone and cartilage destruction all occur. Obviously, we have autonomic nerve dysfunction, so you're going to have vasomotor issues, all the signs of autonomic dysfunction, hypotension, so on and so forth. Again, repeated trauma because they don't feel it, and they get permanent deformities. So this is what a Charcot joint is. Basically, it turns into a big triangle. This is your normal foot, and that's a Charcot joint. Okay, it can also happen in the knee as well, but most commonly it's going to happen in the ankle and the foot. So that's what's going on with a Charcot joint. Manifestations: unexplained swelling in the foot or ankle, because swelling is often painless, but they'll see the swelling, like, oh, why am I swelling in my foot? This is not normal. Erythema on the top of the ankle, increased warmth to the foot, and obviously, as with most everything, early diagnosis is the most important thing. Complications for Charcot joint is obviously amputation of certain toes, depending on how severe the damage is, loss of functional integrity of the foot. These are the ones who have to wear those special boots, the what are they called? They're flat bottoms with the Velcro on top. Less pressure allows the feet area to move, and less pressure under the foot. And we're done for today. We'll pick up part 2 tomorrow.